apresentação.
Pronto. Listo.
Como quiser, começamos.
Graças a Deus.
Já bem.
Agora,
Vamos abrir a apresentação, que corre tudo
solamente
bem.
alguns segundos. Você desliga tu vídeo um pouquinho, porque vou começar falando de umas propagandas, umas coisas, e empiezo, tá bem?
So we will speak in English. So I have to
No
wait.
problem.
Okay.
To start recording now, I have to announce our advertisers, then I will invite you, okay? Just close your video for a while, and I'll be glad to call you again, okay?
Okay.
Bem, boa noite, boa noite. Espero aqui pedir que vocês deem um feedback, por favor, no Instagram e no YouTube. Se você já pode nos ver, por favor. Gostaria que vocês dessem feedback de som. So, tonight it's a pleasure to announce that we have a special guest, Dr. Jacobo Somoza Román from Spain. And we are so glad to have him tonight for a special session. And he will speak about novel digital workflows. And he's a brilliant mind. For those who had the privilege to meet him, I recently met him through Dr. Paulo Cano, who I'm so glad now to say thanks for the opportunity of being tonight in this, for this webinar, for this informal session, I would say. And so you are free to join us and to make your questions if you'd like to now, and you can make your comments. If you have any questions, you are free to do. Thank you, Dr. Botelho, who said that the broadcasting is fine. So, Dr. Jacobo Somoza Román. Dr. Jacobo?
Yes. Hello.
Yes, thank you. Thank you very much for joining us tonight.
Thanks a lot for the invitation. I'm really happy and honored to be combined by you and Dr. Paulo Cano. And I really like to speak in such important society. Well, I'm really happy. As we target, it won't be the first one we will talk, but this time, Fabio, I would like to do a small introduction in our workflow and what we are doing here in Madrid, because I'm here in Madrid, in Spain, and to explain just a little view about, for me, what is digital dentistry and what we have been done. Who am I? This is important because I'm sure most of dentists, maybe I join it, they don't know who am I.
Yes.
And I will try to explain what we are doing and more or less what I've been doing these years. And I think I'm very happy to share with you and what we do here in our Clínica Institute, because we are a Clínica Institute.
You got that, you got me, because I was about to ask you to introduce yourself and tell me the. I know that a lot of people here know you, and the Brazilian audience and people from US and other countries are looking for this moment, and I'm so glad for that. But please tell us a little bit of your background, for how long you are a dentist, and a little bit of your background Please tell us.
So if you want, I will begin with presentation, because that is one thing I was preparing for the slide, just to explain who am I. I will share my screen. Okay.
Okay.
Yeah, you have to. I cannot share still. I need to be. Yeah, you have to let me share my screen.
Yes, I will make you co-host so you can share now the content with us.
Now I can. Okay. So, okay, this here. Okay, so as I told you, we are an institute of education here in Madrid, but it's a small city close here. It's called Guayalmonte, which is a residential area where I started my clinic about, I think it's going to be 10 years. I know it's going to be 9 years ago. So who am I? Really, I'm just a dentist that I really like my job. It's true. I enjoy a lot. As you, I'm really busy with it. And what I try to do is to, since I've been beginning in digital dentistry, I try to do everything digitally as possible. And this is something that I was very lucky, as I would say, because I have the opportunity previously to collaborate with some companies to develop software. And I try to open some fields that when I've been doing digital, we don't have it. And I'm really lucky because I have a lot of people helping us. And I want to share with you what we have doing with this workflow. But my main topic today, and about 5-6 years ago that I decided to be digital, is I have to do everything digital. If it is not, I have to create I have to try to create new workflows, new ways to work with. And today, for example, we are almost doing everything digitally. Almost when I have to rehabilitate one central is when I have to send to a very good lab technician. But in demanding cases, we try to do everything monolithic, as we will show you some tips of it. And we have do a lot of research on it, and that's what I want to explain to you. So here I am in Madrid, where I have my clinic, and the clinic is in the right. It's a small clinic. It's just 80 meters to chest, and where I do mostly all my practice. I'm specialist in aesthetics and in implant dentistry, and close to it is the institute where we have a room where we teach people, and also it's a lab where we plan cases for students, and we try to. The idea of this, Fabio, was I tried to show everything I was doing daily, because sometimes I feel so uncomfortable when I was doing some digital education, and I see the people was not doing these things really. I go to a chairside course, and you see one company is opening a box, and there is the millimedicine, something like that. Everything we do, everything is done here in my clinic or in the lab close to the clinic. And this is the thing most important I have to explain, because I think this is the reality of the things. You have to do it really, and you have to show what you are doing. You cannot show what you are doing. Here in the institute, we have space for 30 people. We have about 26 computers, the big TVs, and we have here in the lab, we have 5 milling machines and 15 printers. So we can have a lot of research on it. We have engineers, we have lab technicians working on it. Okay, and this is something important because we try a lot of machines and we know how to work with this, and also many softwares. So in that room, we receive students worldwide. I think I have told you, we have received students from more than 60 different countries. So here is in the medium image, we have both Brazilian dentists, very friend of us. And mostly what we try to explain is what we are doing in clinic and in lab, and explain step by step of everything. Okay, so what I want to explain some tips or something that we are doing. I think we are doing differently, because I have the opportunity to develop things that I can try on mouth and also in lab. Okay, but as I told you, I'm a guy. The thing is, I'm really fortunate, because this is something that happened to me in 2009 when I began. We used Simpen. It was about 2-3 years using Simpen. I met these guys. These are the guys from Nemo. Miguel Morales is the guy behind the software. Nemo is the software, for example, that Kiss and Kotman used for small design, I think you're right. And Josh, he was the engineer for hardware. And in these 3 years, from 2009 2011, we were developing a lot of things. These are some of the patterns that we have developed. For example, we were the first creating, as I will explain, a guide with sleeves. We were the first ones. Okay, so this is some of the improvements I have done in surgery in this time. For example, we create, this is 2011, we create abutments with the same anatomy root we get from the CBCT. And in that way, we can create the same pontic or same profile of the abutment with the exact anatomy. So it's very easy to work with. Something that we have also developed, it doesn't matter if the patient has a lot of metal in it, we can do perfectly alignment of the intraoral scanners. As you see, number 4 is what we developed. This is the first guide. It's leafless, because we detected that there's a lot of problems with the metal sleeve, so we decided to remove it, and we did print it and mill it, and we realized that the good way is doing mill it. I don't have time this presentation, I will show in other presentations. We are so precise that we screw the provisional right after surgery. Okay, so it is
very good.
So that's what I call this is direct immediate loading, because everyone is doing indirect. They have to rely on or they have to scan. We are so precise with this kind of guys that we screw daily. We and all our students that also send us the guys to do it, and it's amazing. Okay, we have some workflows that I will show you. I think I go ahead. But some of the workflows that we do, the number 10 and 11, we can do workflows of one maxilla or bimaxillary workflows for implant rehabilitations, where we do just everything into appointments, without using scan bodies. There's something, it's a reverse workflow that allows us to go really fast. And those are some of the workflows we develop. This is maybe the workflow that made me most popular on internet. This is one of the most advanced, in that time was one of the most advanced in 3D smile designs. Okay, we showed in 2016. Okay, and as you see, we were invited by Christian Kotzmann to his residency in New York, and he's put in his magazine, he published that, in his opinion, it was one of the most advanced 3D smile design. So we have did a lot of research on it. It's something that we have done these years. Okay, as you see, we can see the movement of the patient. This patient is smiling, and the ears are moving, and this is 2 different positions in facial scanner. We do integration without device. I think it's a much more advanced workflow, and it's not so complicated, but it's how we work with. Okay. Other workflow that we developed in this year 2011 is, as I said, so we were beginning showing to do workflows of full rehabilitations in 3 and 4 appointments. We begin doing 3 appointments, doing with intraoral scanning and with scan bodies. And today, what we are doing is doing just in 2 appointments, as we will explain you in other ways. And things that we have integrated, we were lucky with TShape, and we were using this motion. This is the capture of movement that you say it has in the intraoral scanner, and this that you are watching is a realistic movement of the jaws captured by intraoral scanner. So in that way, we can do rehabilitations, not using a virtual articulator that is not realistic. So we can see which kind of anterior guidance needs the patient, and we can rehabilitate in that way. And this is something that we also develop. For example, as I can get the movement of the jaws, we do physiological spin. This is an example. It has not anterior guidance as usual. So the patient is totally free. And we will do spins where the patient is free as the same movement that we capture with the primary devices in this case. So as you see here, this is a patient movement captured with the programmer, and this is the split we are creating with the software. And you see this is spin, and you will see now the movement. If this is his natural movement of the patient, so this is movement he does when we place at the programmer. So the spleen will be the same thing, and we can adjust with the software in the same way. So the patient will be totally free. This is important because I don't use anterior guidance, because if you use anterior guidance, the mandible will distalize and will close the area of breathing. Okay, so this is one of our development we have done. I think this is amazing, and we do all our spins in that way. And we did it also for one of our students. This is a dentist. This is a brother dentist is placing to his other brother dentist spleen. As you can see here, spleen fits. This is millet one. I'd like much more millet spleen, millet ones. You see, he's adjusting. You see, almost there's no error. And as you can see, he will measure. Excuse me. He will measure with this device. I will go here. This is the 10. He will measure here. As you can see, it's really precise. Okay. So I think with this kind of capture, now we have 100% of patients. We have everything that we didn't have in the past. So what we are mainly, our institute is a research and development innovation institute. We are every day doing research and developing in materials, in workflows. And today we are really focused in chairside workflows. So I have also opportunity to have more doctors here, as Dr. Tapia, that we saw you, he's collaborating with us. He's also working in my clinic. We did a lot of research on it, and we are doing it still. This is a lot of logs we have on the market that look. Some of them are not fluorescent in 405 nanometers millimeter light. This is a problem because no ceramic on the market, is no one ceramic in the market that has fluorescence in that kind of light. And today, this is the normal light on the discotheques. This is the normal light. Because in the past, we used to use the 380 light. This is the one you see in the books. And most of the ceramic are fluorescence with these ones, fluorescence. But in this light, there are not. Only some components are, and this is a problem. Because this is the situation we have. And this is, for example, this is the fluorescence that when you open a book of a paper of a ceramic, yes, the ceramic has fluorescence, but it's not on the right light, because this is black light. This is ultraviolet light, okay, and this light is not used anymore in the discotheque because it has some danger. So the realistic truth is that the ceramics are not fluorescence for the light is used in discotheques or in some areas in some stores, okay. It's something that we have worked a lot. For example, is the problem when we work with vinyl, with dislocates. We have tried a lot of them. We made a lot of cases to see what happened with this kind of ceramics will be the best wall to use feldspathic, the new and the last dislocate materials, we have tried a lot. And for example, this is a complex or case. Complex is a daily case that we use. I will show you, and we compare. There is not the same behavior between different ceramics. It's not the same to use feldspathic or to use dislocate or something else. Of course, we don't use. I tried to avoid zirconium for anterior region. I don't like much to do adhesive, and this is a case. For example, we have a bridge because we don't have canine, and this is in case combining a bridge where we have some problems of fluorence, if you see in the lateral and the premolar, and we have to combine with veneers. And those things that we have tried a lot of materials, and we find some solution as this one, as you see here. So we decide to do a structure, a framework in dislocate, where we will glue, we will cement some veneers over it.
To match the background,
outside will be everything feldspathic with a framework of dislocate, as you see here. In that way, we can avoid the problems of fluorescence and the problem of matching color. So this is something that we have done, and is to try to integrate. And this is everything monolithic. It's very important we do everything monolithic, because I try to improve this kind of workflow, and could be done in a very good way. And this is another, in this case, I'm doing in collaboration with Javier Tapia. He's doing his textures, as I will show you later. For example, it's other case, it was really complicated because now we have a very dark color teeth also with veneers, and we have to do everything monolithic. Okay, I want to do only stained at most, but I don't want to do ceramic, traditional ceramic over it, because it's the way I think we have to work today. Excuse me. As you can see here, we try a lot of materials in that case. For example, those are provisionals, as we see, explain you later. Those are provisionals with our libraries. We use different kind of tip libraries. We try a lot of materials. For example, for the framework of the central to combine. In that case, we will create also a structure to bond another veneer over it to try to match the color. And when you see, if you use this kind of workflow, it's not so important the framework are using, because the most important is what you place over it. Always we try to use feldspathic. As you see here, if you do a good combination, a good color matching and documentation, as you see here, with 6 different frameworks for the central, and you can see as we do this kind of model, different models we use for this kind of workflow. And in that way, we can achieve reasonable aesthetics if we combine correctly this kind of monolithic materials. You see, this texture is done handily by Javier Tapia, and the matching of color is acceptable if we use this kind of workflow. And we are working a lot of it. We are doing a lot of research with implants. So now we are holding several studies to try to do everything in that way. Which material is the best to try to get both fluorescence, and which is the best in terms of adhesion, in terms of opacity, etc. And a lot of times here you cannot mill thin veneers. Of course you can mill thin veneers. This is some things that we have seen done in our lapping clinics. Those are really thin veneers, but normally we don't work. I don't work with so thin veneers, because normally I want to change the anatomy of the teeth, and it will give you much more space for it. As you see, this is just 0.150 microns. It's just really thin. But if you know how to mill, and we do different strategies with engineers, so because we do something different with the cam of the milling machines, we have 5 different milling machines. You know, we have a lot of workflow and knowledge in milling, and we try to do something different, as I will explain you. In that time, this is about, I think we saw this was 2 or 3 years ago. I think this was 3 years ago. We began to try to do pre-chematias in the veneers. So we changed the way as the milling machines were working with engines. As you see here, this kind of of pigments we're doing with the milling machine is so artificial, but it avoids to be flat, okay? And we did it with different strategies on the cam, as you see here. And we realized that there's a different degree of pigments from the sisal to the cervical of the teeth, as you see here. And we study how much difference is in that kind of pigments. We try to give this information to the milling machine, as you will see here. This is in normal, as you see, different degrees, and the last one that we did it hybrid. So it's not the same. Close it is not when we have the incisorial and the cervical area, we don't have the same space between the pigments, okay? And that's what we do it with the milling machines. As you see here, normally the machine works like in the left. It bursts, as you see, doing round. So we change the way as the machine mill this buccal area to try to do this kind of texture, to avoid doing flat. So we can do not only macro textures, so we try to do also micro textures on the veneers. So we try to we do different strategy, as you see here. This is the left one, is the normal one done by the machines, and we do a hybrid texture inside the milling machines. This is really a workflow of engineering that is also a phenomenon if you try to avoid this kind of things. And we do a lot of them. So something that you will see here, I will show you another workflow that we also have to agree doing this. Not only pigments, also membrane. This is a technique of membrane is a technique of Lawrence Strand, is one of our teachers in institute. So we get macro textures. So over the veneer, so we can recreate not only pigments, we can recreate also macro texture. So it means that we don't have a normal, a regular veneer with this kind of CAD/CAM workflows. So we try to improve and to achieve the most, or to try to achieve naturality with the machines. And that's what we have worked on. This is one example. Also here, milling a veneer with this kind of technique. As you would see, we go further because I think this is you see, this is what you will see on the machine. If you try with the core workflow, you will have a very nice texture outside. Okay. And today we are doing also handling. We're explaining how to do handling because we have worked a lot with machines. So we have two ways. We do digitally, and also we teach our students to do manually. And this is Javier Tapias. For me, is amazing. It's a lot that is with us in the clinic and the institute, and he do very beautiful testers. As you see, this is about 1 month ago. We did a course where we milled in live 12 veneers in 2 milling machines in less than 4 hours, in 3 hours. So we have 6 veneers in each machine, and I think we mill it in 3 hours and a half, 12 veneers. So this is amazing because you can do really fast veneers with this kind of machines and workflow. And this is what I want to explain today, Fabio, is if you let me to summarize what is for me, one of the lacks of dentistry that the libraries that the normal dentists or labs are using are wrong. This is something we saw about 3 years ago, is that we are doing different libraries. As you see here on the left, our libraries ends on the neck of the teeth. So we can have natural scale of the teeth. We do libraries in a different way. It's not like a neck. So normally the libraries in the cervical area is like a neck. So it doesn't ends in a clear margin. So this is important because with this kind of teeth, we can do the diagnosis. As you see on the right image, this is a defect. And you can see if you place this kind of teeth, where you need to place the gingiva, where you need to place the papilla, where it should be the implant and everything. And those are other kind of teeth. You see, they don't have N, so they are not clear. If you see and you compare this defect, this kind of teeth give you the volume of the defect. There are diagnosis teeth. And how we create it? We create from natural teeth, and we end just with the scallop of the gingiva. And it's very important because all our workflow is done with this kind of teeth. For example, you see it's an implant case where you can see on the left of the implant of the patient, there is not enough gingiva there. So I will do a graft, soft tissue graft there when I will do the implants to gain and to try to regularize the margins. It's everything we do like that. And this is the workflow I want to explain to you today, is why we are working with this kind of libraries. Excuse me, I have one slide in Spanish. So we can, this kind of libraries help us to position correctly the implant, because implant should be at 3 or 4 millimeters from the margin. But if you don't have a library with this information, you are really lost. So we used to position the zenith, the papilla at the margin, and a really useful anywhere at level, surgical level. As you see here, in that way, we can create even a graph doing detail to know how much space we need for the bone graft, how much space we don't need to software, so graph, and where to place the implant, as you see here, because this kind of teeth are totally diagnostics. So help you to know, as you see in the lower left image, how much of tissue I need in that case. And also when you do the regeneration, you can compare, you can do a scan, compare if you are right or you are not, and how much soft tissue that you need, because sometimes you need to know where it's wrong to achieve wrong. If you don't know where it's wrong, you won't achieve wrong. And this is really important because the library has to give you this information. Okay, at the same time, as show you these cases, we do grafting, and that's the way as we do it. I will show you 2 cases with this kind of philosophy. And this kind of teeth, as you see, we can achieve natural smiling because this teeth has this kind of neck, and we do a preparation with this information. And also we have this information to do orthodontist cases where we do integration also of the setup facility with Invisalign. And we can know how much movement do I need to move my teeth to do non-preppiness or not almost preppiness or prepless or not so invasive veneers. So I can give the movement, for example, this is a patient with no laterals, and we can integrate the movement, how much do I need to move the teeth, the gingival margin, everything is guided facility with statics and with this kind of libraries, okay? And those are our libraries we are using normally, okay? And those are the most important thing, I think, is your tool, because I don't do silhouettes in 2D. I think it's unuseful because it's much more important the information that you have in a natural teeth, because it depends if you are safe, if you do some cleansing, the silhouettes are not useful. So I'm against using silhouettes on the smile design. So I will show you just 2 cases to see how we do this kind of workflow. So I show you how to do facially guided crown enlargement, where we use this kind of libraries, not only for the enlargement, also for the veneers, and you will see the integration. This is a guy that we did it in Invisalign because he has almost placed 3 positions of the teeth, and we don't have enough room to rotate, so we do some expansion and we create some space over it. In that way, we can rotate the patient. And as you see here, this is the patient after Invisalign. You will see here. So he's smiling. Now, what we will do the smiling sign. We will do the crown enlargement with our libraries. This is our guide to do this kind of workflow. This is important. You have to understand, because this kind of guides are different. We use different types of it. I try to do with the same anatomy. We do all these surgeries closed. I didn't open any flap. You have this video on YouTube. You want to see the surgery, okay? So and this is patient after 3 months. I always we place another time the mockup, and this is the result. I just want you to see the anatomy of the gingival scalp. Look to the gingiva. As we have natural scallop of the teeth, you are seeing a natural teeth. You will see better in the last video. So this is natural scallop, and this is before and after. Everything changes if you use this kind of libraries. The gingiva is the trick. The most important is the scallop of the gingiva. That's what you will see. The teeth are realistic ones. So Fabio, we do the crown enlargement and we do the preparations with this kind of libraries. Okay, I will show you one case again. Can you hear me, Fabio?
Perfectly.
Yeah.
I'm following you. I'm watching you closely and thoughtfully because it's amazing. It's amazing. Your workflows are simply amazing.
I will show you one technique that is I think it's the first time we saw 2 years ago in Madrid. This is a new technique. I will tend to explain it to you because with this kind of libraries, I have patients that, for example, most of my patients I treat, they are older, they are women, so they have lack of gingiva because they have some recessions because of the years or because some fraction, and they get loss of the volume of the gingiva. They have a vertical and horizontal loss of the gingiva, and it will create lack of support for the lip. And this is a very big problem because when I see some treatment of this patient, when the normal regular dentists are doing veneers, the veneer will be over the teeth like bricks. So the veneer will be far away from the gingiva, and it will create some artificial feeling, you know. And what we are doing, I will try to explain you. You will see a patient where I treat with this kind of teeth. The teeth, as you will see in the smile sign, will be about the neck of the teeth will be about 2 millimeters buccal to the regular teeth of the patient. And I will do grafting to improve this kind of situation and to try to give down gingiva to the patient and also support. Okay, this is important to explain you that for me it's the most important thing. How important is it that I will show you my mother? This is my mom. My mom is 74 years old. So as you see, if you see in this this picture, this is before, this is after Invisalign. Also, we are doing almost of treatment with orthodontic. You can see the lip, it has not enough support. You can see vertical hooks because there's not enough support. I will try to explain you as to stop what we are doing here. So you see here, when you see, she has sonorations, she has fractions, she have not good occlusal plane. As you see, it's bruxins and it's not okay. So I will place my libraries with the mockup, and you will see this kind of, as I tell you, this kind of libraries when I can see very well where is the neck of the teeth. Okay, I want to explain you how this workflow works, because now when we place this kind of libraries, you will see a difference between our neck, okay, and the gingival margin. So if you see here, I need about 2 or 3 millimeters of lung enlargement. You see, aesthetic looks quite good, but it's not good. It's awful. You know why? Because we are watching the patient frontally. But you see laterally, as you will show you here, this is the trick. This is the problem. Fabio, if you see the neck of my mock-up, it's about 2 millimeters frontally to the gingival margin of my mom, and it's also 2 meters incisal, okay? So I have a problem because the gingiva is very far away where I want to place the gingiva. What I will do, I will do soft tissue grafting over the mock-up. And this is really important you to understand it. Here, this is the main difference in this neck. So if I do a regular soft tissue grafting, the dentist will only gain vertically the gingiva because the teeth is back. Okay, but if I play a mock-up and I do soft graft, the soft tissue graft over the mock-up, I will push, as you see with sutures, I will push the soft tissue forward and lower. So I can.
You will use the mock-up to support the graft, is it?
Yes, I will. With sutures, I will push my soft tissue forward and down. Okay, so I will gain about 2 or 3 meters, not only vertical but also horizontally. I'm gonna give a down gingiva to an older woman. I will see how we do it. But it's important. If I don't have this mock-up, I cannot push forward because I don't have where to push.
Yes.
Okay. Mm-hmm. And this is the where I will see you now how we do it. Okay. So you will see some surgery now, and I will show you the result. So this is the problem. We have a very lateral problem. So she doesn't have enough lip support because there's no gingiva. Gingiva is lost, but vertical and horizontally. So teeth is beautiful, but we have problem in the neck. So we need to push the gingiva down and forward, but a lot of it. So imagine how I believe in it. I take soft tissue from the palate from both sides of my mouth. As you see here, this is to summarize. I don't know if you see it. I gave both sides. This is one side, and I cut it to give in my mouth, and this is the other side, and I cut in two. So I get a lot of soft tissue from the palate, a lot. And this is important when you see the suture. So the main problem is here, is horizontal. I need support here. So I will place the soft tissue here and the other here. So the most of the volume will be here to gain not only vertical, but also horizontal. As the soft tissue won't can attach to the mock-up, it will get the natural gingival scallop of my mock-up, as you will see here. And this is what we try to do. So we do tonalization. This is like a Vista, it's a like Vista technique, something like that. We try to push really forward and down, a lot of it, and you will see the result. Okay. Now, so this is before the mock-up. The mock-up is after the soft tissue graft. I want you to see how much soft tissue we gain. I don't know if you're watching. This is differently. This is something wrong for me, Fabio.
Yes, the volume. We can see the volume, a lot of volume.
It's a lot of volume, yeah. Normally, Venice, if you treat an older woman with refractions, you cannot place the margin. I don't know if you see the mouse, because it won't be natural. It won't be a very long teeth. It won't be beautiful. And this is a problem. And the veneer will be over the gingiva, will be more buccal to the gingiva. So when the light comes, you will see a darker gingiva. But what I want to always to be, I try to gain my veneer has to be inside the gingiva, like in a young patient, okay? And it will look much more beautiful. What we are gonna do is that, as you can see here, we're gaining a lot of volume. But most of them are in the frontal area, where you remember I told you I placed two grafts, they are crossed, so I can give much more lip support, as you will see in the video. In that way, the people now looks like a young gingiva, much more younger. So now
another thing, another thing, the lip movement changes a lot. More attention to the lip.
Yeah. Now they will, as you will see, he will have a down and down and smile. This is really important. If you see this, if you did this kind of work for the veneer, will be always outside of the veneer, outside of the gingiva. But in that way, as you see here, we give a lot of soft tissue. Remember, my mother has a lot of erosions, so I try to do as much more as to prepare the less I could. But if you remember, she has a lot of erosions, as I show you here. The previously here you see it's almost everything is erosion because of acid. You see it. So these are like 340 degrees veneers. Okay, and this is the situation. These are the preps, and I will show you the workflow. So these are veneers with Iberpekimatias. Those are Empress multi. So we mill it with Pekimatias, I would say, Iberpekimatias.
So all these perikimatia were produced only by the milling machine, is it?
Milling machine. We do different strategies to the milling machine. Yeah. This is
for those who don't believe that the milling units are able to do that. That's the proof.
Yeah. you cannot do in all milling machine, but this is important. But we were the first doing different degree of veneers, because you see here in the incisional area you have closer Pekimatias, but on the cervical they are far. They are not so close. Okay, so we have to do arbitrary, like in natural. We measure. We have doing research how much distance are between Pekimatias. This is a lot of research about it. But look one thing. You see, this is my neck. You see, this neck is equal this one, but you see the gingiva is slightly upper, but the neck are at the same level. I will explain you this thing because this is important. When I finish the case, it will be on the same area. One thing I didn't tell you is very important. I do all the veneers without margin, because now I have a problem. You will see when I remove my provisional. These are the provisionals. I place provisional pedant 15 days. So I prepare patients. I place a regular provisional. 3 days later, I place printed provisionals, 3 printed provisionals, and I will keep the patient 15 days with the provisionals. Why? Because I need healthy soft tissue, as you see here. And look, this is when I remove my provisionals, you will see the gingiva. Look at the gingiva. You see the scallop of the gingiva, how thin it is and how hard it is. But I have a problem, Fabio. I cannot. You see, I have a lot of soft tissue. I don't have margin. I cannot place rubber dam. It's impossible because I don't have any margin. And if I place a rubber dam here, a clamp here, I will do some problem. I will have problem with the soft tissue. So this is a reason because I have to place provisionals pedant 50 days, because I need really, really healthy teeth. Look the sulcus. It looks like I have been with this 1 to 3 months. Look the gingiva. You see? And now you see it's the same anatomy of the provisional and you see now I have natural scallop of the gingiva with my library. And look now, if you see here, this neck and this neck is the same one, but here you have a lag because I need this margin to be a little down, and you see I say grafted. When you see it 3 months later, you will see the margin is on place.
Yes, because you gave space to the tissue to mature.
You know what happened in that case? You know that I placed some suture over the center. Some of this suture fell previous than A1. Normally, I keep the patient 15 days with the suture, and this suture fell 2 days later. So it's not a problem because the soft tissue will go down when you have sterilization of the veneer. And you will see this veneer after 3 months will be down because I did a soft tissue. This is the creeping of the gingiva. You will see now. And this is the train of the veneers. And you will see my mom. It's a train with scallop. And look, now, Fabio, I have my mom with teenager smile. This is teenager smile, not young smile. It's teenager smile, isn't it? Look. This is beautiful. This is a young woman. His friends say she looks 10 years younger. I tried my mom to change the color of her hair. I say no, but to do the finals, but she doesn't want. But look,
don't give her any new problems, please.
But look, the difference between a patient with no lip support and all their teeth and now beautiful young smile. And this is my philosophy. 3 months later,
along with the texture, this aspect of lip support is amazing in this case, really.
Look, this is something in microscope, just to see that the healthy, when I remember we don't have a margin in the veneers, but look the healthy of this is with microscope. And now you see the margin of the 21 is on place. It's totally healthy. Healthy. And it's the work we do. What's most important is our library. The library is the trick. Now we have the natural scallop of the gingiva. And that's what you will see beautiful teeth, because it's not done like a nova, like a neck. It's natural. And always I have to give the gingiva to the margin, or I will do large attachment, orthodontic treatment, or if it's necessary, grafting. Do you remember the fraction of my mom? Now we have a scallop, a natural scallop gingiva. And you see all this is gingiva. Okay? And source support. And this is, I remember I saw you, this is the last slide I will show you. Remember I told you that we did a one month ago a course, a live course of chestside. This is the work for you have to understand. We do it, this for example, this on the left side, we place veneers to the patient. She wants to be white veneers, okay? So on the right, you have printed ones, the same ones. We don't have so white color on printer resins, okay? So the patient will be 15 days with the printed ones. When I remove, you will see what happened with the gingiva. And always, this patient was also an older woman where I did it soft tissue graft and orthodontic treatment. Look, and this is the texture that Javier did it in live in that course. Okay, in just half an hour, he did it, this amazing texture. This is handly done, okay? So we do this kind or natural by a very good guy that knows a lot of anatomy. It's amazing anatomy. I don't know if you know Javier Tapia what is. He's one of the best in aesthetics worldwide. Amazing guy.
I'm sure.
And
he was here watching the webinar. He is here.
I see. Hi Javier. How are you doing? Amazing. And look, these are frames from a video. Just to, and you understand it because I didn't pictures. Is when I remove the provisionals after 15 days. I want you to see how is this gingiva. Remember, I removing. Look the gingiva. You can see this thing and peaks, this mountain of the gingiva. This is what I have. Okay, so and this is trying. So I will get natural, totally natural scallop gingiva. And the trick is the library. And of course, you have to do everything guided by facially guided. So do all our aesthetic are guided facially with, and this is important thing that I didn't have time to explain, but normally what we have some these years is that normally all the small designs are mostly down frontly, but it's only about 12 o'clock view. That's beautiful, but we have to work more lateral. I don't know if you can see me on the webcam. So I give a lot of importance to work on 45 degrees, where I can put my crucial plane. I can have much better contour of my torque, and I have much better contour of where I have to place my neck. And I can see better lip support. That's the reason when you see to my mom and this kind of patient, when they are getting older, they are losing gingiva and they are losing resultant volume. And if we have to give them this situation, and they will look much more younger because it's not so important to do filling of the lips in older women. It's much more important to do filling of the gingiva. Of course, in the end, they can do small fillings, but the most important is they don't have enough gingiva to support the lip. So if you do fillings and you don't have gingiva, it's unuseful because you cannot give this a kind of support. And this is what we try to give young smiles to other patients. Okay, everything is in the library and the diagnosis. Okay, so it's done. I think I mostly explained everything.
I think that the audience is having some problem because they unfortunately they didn't ask anything, but I can say them that you are free to make any questions if you wish. We still have some time here, but I have one question for you, Dr. Jacobo. What do you think after this? According to your experience, what do you think that the audience can expect in the near future when it comes to intraoral scanning and other devices and other technologies that are emerging right now? What do you think that we can expect in the near future?
From veneer, okay. Now we have new materials. We are working out. We have blocks that have a natural opalescence. For example, we have the one we are working but 1 year ago from, for example, LISI is a material that you don't need to try to gain the halo, for example, the opalescence halo, because this material, when you cut it and you do the regular anatomy, the halo, opalescence halo, will appear naturally, for example. So this kind of ceramics much more better with the teeth. So this is a new way to do ceramics, because we don't need to do multilayer ceramics, because multilayer ceramics is not a natural ceramic, it's a degraded ceramic. And this kind of material match perfectly. I don't know if you see this picture. This is from Javier. This is the case he did it. This is kind of ceramic we are working with. And this kind of ceramic is totally, it has a beautiful matching with the teeth. For example, those are feldspatics, those are wet feldspatics. But when we work with this kind of materials, they're amazing because we have materials that even as LISI, you don't need to go through the oven. So I can do veneers without needing to go to oven. I just can texture it. For example, those veneers have no glazing. They were just polished. But this kind of
milled, they have polished and cemented.
If you see Javier Tapia profile yesterday and today, I don't remember, he shared some inlays and onlays with this kind of material. He did it. He cemented today. I saw on mouth. Amazing. But this, and there is no staining, but the behavior, the aesthetical behavior is so natural that it matches perfectly. So we don't have to always to dark the sulcus and something like that, because there are patients that they don't have a tinted sulcus. In this kind of patient, you don't need to do any painting on the teeth, and they match so good. And this is something amazing. But in terms of use of technology, I think for me, what is most important is the diagnosis. So we have to go from the facial integration to the library, essentially, because everything has to be guided by this kind of libraries that, you know, when I do preparation, if I was very important, I don't do like that. I do with the same anatomy of my library, because if I don't do like that, my teeth won't be the same. We won't have the same anatomy. Okay, this is really important. So I think we have a lot of things, because, for example, we now, as you see, we have guided preparation systems that are working on it. Okay, but I think the most important thing still is diagnostics. We have new materials, amazing ones, and we can mill really thin. But I want to explain you something important, because there is everything is like, if you don't do really thin veneers, it's like if you are not doing good aesthetics. But the truth, if you prepare something, as I saw you in the veneer, as I told you, I saw you some slides ago, before, you cannot change color and you cannot change anatomy. So with the my veneers are regularly between 0.3 0.4. Of course, sometimes I have to prepare a little bit, but I don't prepare much. But I need this kind of volume to change anatomy also, because this kind of teeth are younger, and we have patients with rounded teeth, and we have to give much more volume. So it's not so important to me. I think the important is the optical properties of the veneers, and we have amazing ones now. Okay, I don't know if I answer your. I think that the new will be in the material. This material are amazing.
What do you think about printing ceramics?
Okay.
I believe
honestly,
there's a trend worldwide about that.
Everyone is asking me always that printer will be much more better than milling in a few times. And I explain you always the same thing. For example, if I saw you before a splint, a crucial splint, and you say, why don't you do printed? Okay, I don't do printed for one reason. When I mill a block at this of PMMN, this PMMN was done with between 200, between 2 and 180 atmosphere of pressure. Do you remember when we were doing analogue spins with liquid and resin? If you don't go inside the oven, inside the pressure, the resin won't be very good. But the good thing is when you are milling, all the material is done in the best conditions possible. So they are really condensed. You don't have bubbles in the blocks. This is something important. When you mill a ceramic, there is no bubbles. So this is no problem. The problem is the printer, they are not doing inside industrial conditions. So they are doing a regular atmosphere. So they are not condensed materials. For example, when I explain you next or the other when we will talk about sculpture, when I do a printed guide, you can you can see the material is easily to remove because it's not so hard.
Yes,
okay?
yes.
And this is a very important thing. The ceramic in the industrial way will be ever better. No way. I'm sure of it. So other thing is that we can do stratify and color. Okay, and I've seen materials, but this is a problem. This material, most of them are with photo materials. They are not ceramic. They are like composite ceramics. So I don't think this is a feature. I have tried.
Actually, they are hybrid materials.
There is DFAB, for example. We have tried here DFAB. DFAB is an Italian company that they have a layer color printed materials. It looks good, but it's expensive. Technology is still okay. Could be the future, but I don't think it will change the ceramic. It will be maybe it will change the composite material because there's several classification of ceramics now. You see all the composite are ceramics. For example, I don't think a material that have a matrix or a matrix is a ceramic. For me, it's not. But the regular classifications give us a ceramic. But I don't think it will get the nature of, for example, this kind of new materials we have with opalescence that they are magical, or this kind of sphatic materials. I don't think they won't get it. Not today. Okay, and this is important. They are mostly, if you do at your home, they are doing in atmosphere situation. So it cannot be so condensed as you do with pressure. 100 atmosphere of pressure is a lot. So you can do much more condensed material and much more resistant materials. We know that. And this is an important thing because the new blocks that we have in this silicate, I didn't tell you, we have Tessera. Tessera from Dentistry is a new silicate. It's also opalescence. It is so strong as the zirconia. As the static
from Dentistry Sirona.
Tessera is you have to go to the oven to achieve 700 megapascals of resistance, like the zirconia. So in the future, I think I think we are going to use less zirconia and much more blocks of material that they have better behavior because they look like a teeth. And you have also Lisi. Lisi is a missing material. You can mill really thin because you have different particles. You don't need to go to the oven. So you can do a very fast workflow. I think this is the future. I don't think to place more composites on mouth printed will be the future. Honestly, I don't think so. Of course, it's another possibility, cheaper, but won't be as good as the ceramics ones.
Let me tell you one thing. I just realized that our friend Laurent Stumpf he's joining us in Instagram. He's watching you, and he said your lecture is excellent, and he's mentioning about your education in digital in your institute. Laurent can check this at the beginning of this recording, because you mentioned about the education in your institute and the courses you give out there. Is it right? So we can we think about another opportunity to speak more about any topics you may wish, Dr. Jacobo, because
sure.
First time and here in Brazil, as you may know, is a little bit earlier than people are used to watch the episodes. Here is now 7 p.m., for example. So happy and glad that you could join us. Now is 11 p.m. or midnight in Spain?
Yeah, it's 11. It's 11. Yeah.
11 p.m. So it's so late now. It's so late there in Spain, and people are so grateful for the opportunity of listening you and watching you here. This episode will be available in Instagram, IGTV, and YouTube channel, and hopefully within a few days I will add some captions in Portuguese for the Brazilian audience, and maybe we can speak within the next few weeks in another opportunity to show a little bit more in detail some of your workflows or any topic you may wish or you deem it necessary to spread through the people. Okay?
I will be honored to do it again. Okay. So Fabio, thanks a lot for invitation. I enjoyed a lot, and I hope I can show something new. But I think there's a lot of still we have a lot of things to do it. So I think, but we are in a magical moment, because now we have amazing interest scanner, amazing milling machines, amazing printer, amazing materials. So we have amazing softwares, so we can do a lot of things. So I think we are really lucky, because dentistry is changing so fast, and we have to be there.
Yes. So as a friend of mine used to say, when we speak about digital, we think about technology, but digital means fingertips as well. So we cannot lose this meaning.
Yeah. It's true. So
okay, my friend.
So see you next.
So see you next month, or we will announce as soon as possible the next episode. So thank you very much. Thank Dr. Paulo Cano for the opportunity to meet Dr. Jacobo and for this webinar, and we'll keep in touch. Thank you.
Okay. See you.